Good afternoon everyone and welcome to today's webinar. This is the first of a series of 1-hour webinars we will be running over the next 5 weeks. So every Tuesday from 1 to 2 p.m, please join us for one of these free webinars on chronic disease prevention. I'd like to welcome you all here today. My name is Katie Smith and I'm an improvement consultant here at the Improvement Foundation. I also have with me Sarah Raverstein from the Improvement Foundation and 2 guest speakers who I'll introduce later. Before we start, I just wanted to share a little bit of information about the Improvement Foundation. We are a national not-for-profit organisation that provides training and consultancy services in the development and delivery of quality improvement techniques and programmes. You may have heard of us through the Australian Primary Care Collaboratives programme, which we developed and managed for over 10 years. We've worked with thousands of health services around Australia to implement quality improvement initiatives that aim to improve health outcomes for patients, improve the efficiency and effectiveness of services by streamlining their systems and reducing their costs, and to improve population health more broadly. So as I mentioned earlier, this is the first in a series of 5 webinars focusing on chronic disease prevention. Earlier this year, SA Health contracted Improvement Foundation to run a workshop on chronic disease prevention. They also asked IF to run a series of webinars based on the workshop so that people from across South Australia could attend. So thank you for joining us. This first session is designed to set the scene for the series, to give you an understanding of why prevention is important, and to give you an overview of what can be done to strengthen prevention activities in your workplace. We will also be hearing from 2 guest speakers today, Lyndall Thomas from SA Health and Verity Patterson from Country SA Local Health Network, who will be talking about services relating to prevention in their regions. Welcome to you both. On this slide in front of you, you'll see we have 4 learning objectives for today's session. Please take a moment to read these learning objectives so that you can reflect on them at the end of the session. Once we've finished today's webinar, an evaluation form will pop up on your screens, and we will be asking you to rate today's sessions based on these learning objectives. So, what do we know about chronic disease? It's no secret that health costs are rapidly rising, and that the ageing population and the burden of chronic disease are major contributors to this. Cancer is the leading cause of fatal burden of disease in Australia at 35%, with cardiovascular disease following at 23%. On the screen in front of you now are some statistics from the Australian Institute of Health and Welfare on specific chronic diseases or risk factors. In 2011, over 1 in 4 Australians, 29%, either had cardiovascular disease, diabetes or chronic kidney disease. 7% of Australians, or 1.2 million, had at least 2 of these conditions, and 1%, or 182,000 Australians, had all 3 chronic diseases. Of the risk factors for chronic disease, smoking is still considered to be the one that is the most risky behaviour of all. And whilst there have been great successes in a 15% decrease from 1998 to a smoking rate of 13% or thereabouts, unfortunately we know that it's a higher statistic for those of Aboriginal and Torres Strait Islander backgrounds, of whom 42% aged 15 and over smoke. Another risk factor is the lack of exercise. Over 1 in 2 Australians at this current point do not meet the physical activity guidelines. Let's now look at some data from SA Health on admissions around the state between 2014 and 15 for 2 of those chronic diseases, namely cardiovascular disease and diabetes. And as you can see, for cardiovascular disease, there were over 27,000 separations, equating to more than 120,000 bed days with an average length of stay of almost 6 days. Whilst there were less separations for diabetes, you'll notice that the average length of stay was almost 7 days. And here we have an estimated public hospital admissions attributed to obesity. And this data reflects contribution from obesity to other causes. These admissions equated to 4.6 of the total of admissions in 2007-2008. However, it's been predicted that this will increase to nearly 6% of all admissions by 2032. There's also information on bariatric surgery, and the rates of this have increased by 400% in 10 years. There are many other costs related to obesity to consider: larger beds, surgery tables, lifting devices, specialist ambulances, and injuries to healthcare providers. Many chronic diseases are preventable, and one of our roles is to consider how we can help our patient population to reduce some of the risk factors that could contribute to chronic diseases. As I mentioned before, smoking is the most insidious risk factor, but there are others too. As you'll see from this slide, only 11% of Australians in 2014-15 met the recommended 5 serves of vegetables on a daily basis. And almost 20% of those Australians drink more alcohol than is recommended. The physical activity recommendation of 150 minutes of moderate intensity activity, such as walking, is suggested on a weekly basis. But as we have already mentioned, less than 50% of adults are meeting this recommendation. I'd like to acknowledge that the next few slides come courtesy of Professor Mark Harris, who is the Executive Director of the Centre for Primary Healthcare and Equity at the University of New South Wales. Mark Harris has been studying and publishing on chronic disease management and prevention in the primary healthcare sector for some years now. So why do we focus on prevention in primary healthcare? One of the reasons for that is that we know that more than 80% of Australians aged 18 and over will visit their GP at least annually, and 45% will attend 4 or more times a year. There's often a long-term relationship between a GP and their patients, and that enables continuity of care and ongoing dialogue and discussion on things like reducing risks for chronic disease. So one of the studies that Professor Mark Harris and his team undertook was the Preventive Evidence into Practice study. 112 GPs and practice nurses were recruited at baseline, and 97% of those continued on with the study for a full 12 months. Almost 22,000 patient records were audited for those aged between 40 and 69 years who had attended the practice in the previous 12 months without a diagnosis of heart disease, stroke, diabetes, chronic kidney disease, cognitive impairment, or severe mental illness. And from this study we can see that there are some wins and some not so strong areas in terms of recording of risk factors. Blood pressure and smoking are very often well recorded, above or near to 70%. However, waist circumference and alcohol intake were not very commonly recorded. So this gives us an indication of areas for improvement. In addition to there being room for improvement in the recording of risk factors, Mark Harris's team have also found that only 7.1% of encounters, was preventive advice given to the patient. There's also room for improvement in health assessments, particularly for Aboriginal and Torres Strait Islander peoples. And importantly, referrals onto either programs and/or allied health providers who might be able to help the individuals to increase their healthy lifestyle and reduce their risk factors. A recent study in the Medical Journal of Australia found that about 1/5, or 1.4 million individuals of the Australian population aged between 45 and 74 were estimated to have a high absolute risk of a future CVD event, but that most of those, 970,000, were not currently receiving recommended combination therapy. Now, we know there are a number of barriers to prevention. The primary care sector is a very, very busy place, and we all understand that it's difficult to manage the workload on a daily and weekly basis. In addition, some of the team members may not feel confident or competent to undertake prevention activities. Some people consider that the MBS is outdated in the way that it funds the care that's provided in primary care, and that there is a very little business case for prevention activities. One of the webinars that we're holding in this series, the final one on nurse clinics, will give you a business case as to what you can claim from the MBS and how you can support the work of prevention by claiming effectively on all the item numbers available to you. Another barrier to prevention is the attitude of individual healthcare providers and clinicians. It may be the case that some people feel that prevention is pointless because patients don't always listen to what the clinicians say, and they feel disheartened that their advice is being ignored. There are also barriers to prevention from the patient's, client's or consumer's point of view. There's been a lot of work done in the last 10 years or so on understanding the different health literacy rates for different individuals and different groups. And it may be the case that the patient whom you're working with does not really have the health literacy to understand the conversations that you're having. If you work in an area with a high population of people for whom English is not their first language, there can also be language barriers and cultural norms that don't allow prevention activities to be put in place easily. And again, depending on where you're located in South Australia, you may find that referrals to allied health or relevant programs are not as accessible as they are or as you would like them to be. In addition, they may be expensive for your patient cohort, or there may be transport issues that make it very difficult for the patients to attend either the allied health providers or the programs that you're referring them to. However, it's not all bad news. There are some enablers that will support you in your prevention work in your general practice or health service. The majority of general practices now have strong teams comprising of GPs, practice nurses, practice managers and the admin staff. And if you're able to work together as a team and share in the load, you will find that you are much more effective at providing prevention activities that suit your patient population. There are a number of different IT systems and tools that enable you to analyse both your population and individual health data. And you can then determine who might be the target group that you would like to work with. There is dedicated funding in the MBS for item numbers regarding health assessments, for example, and they can be utilised effectively to build a business case for your prevention activities. As we mentioned before, there are often very good and very strong clinician-patient relationships that have been built up over a number of years. And these relationships, if they are respectful and supportive, really do enable engagement of patients in prevention. We've all heard of Dr. Google, and whilst we might roll our eyes at the thought of our patients going on Dr. Google, what is happening is that it is increasing people's awareness of health issues. And finally, there are models that are enablers, such as the stages for change and motivational interviewing, that can help you understand a patient's readiness to put in place changes to reduce their risk factors and improve their lifestyle. So where to start and what can be done? Over the course of the series, in the next 4 webinars, We will be asking speakers to come along and share their experiences with you in how they have implemented a systematic and proactive approach to prevention in their own services and systems. It's very important to know your practice population and to use the data from your clinical information systems, such as Medical Director or Best Practice, and also via third-party extraction tools, such as PenCat or the Canning tool or Doctor's Control Panel. We've already talked a little bit about teamwork, and I think we can consider that the team isn't always the one who we work with on a daily basis. It may be that the team broadens out in the area of prevention, where you're working very closely with allied health providers and programs and services that aren't located in your practice or service. The Australian Primary Care Collaboratives Programme utilised the motto, share generously and steal shamelessly. So what we are hoping is that you get some innovative ideas over the course of your participation in this webinar series that you can use and take home and apply at your own practices and services. So where to start? Well, I would recommend that you start by building the team and considering what particular prevention activities you would like to focus on. So what will you start with? Will you be targeting a particular disease group, for example, diabetes or chronic kidney disease? Who will you focus on? Will there be a particular cohort of patients from a particular age group? Who is going to undertake the prevention activities? Will it be singularly the GP, or will it be a team approach that includes the GPs, practice nurses, and the admin staff? It's important to consider the setup in your general practice or health service and make sure that you have a space, a spare room, for example, that you can set aside for prevention activities during individual sessions over the course of your working week. And how often will you do this? Can you allocate one session a week to begin with, or maybe two? Our experience in the collaboratives has shown that it's beneficial to consider starting small, with maybe one GP, one practice nurse and one session a week. That way you can iron out any problems that you have without causing too much disruption to the day-to-day activities going on around you. I'd now like to welcome our two guest speakers, Verity Patterson and Lyndall Thomas. Verity started her career as a social worker with the Department of Community Welfare, where she worked for 14 years in the child protection field. Since joining Health in 2012, Verity has worked in a range of roles, including Regional Director, Executive Director of Aged Care, Manager of Service Delivery, Corporate Services Manager, and Manager of Community Health. She is committed to rural communities, having spent all her working life in rural South Australia. Verity currently oversees the delivery of the multidisciplinary community-based services and allied health services in the acute sector across rural and remote South Australia. She has clinical governance responsibility for allied health professionals working in the Country Health SA local health network. Welcome, Verity. Lyndall Thomas is a Principal Project Officer in the Public Health Partnerships branch of SA Health, and she has qualifications in psychology and health promotion. Lyndall has almost 20 years' experience working on programs and services relating to behaviour change, and her current work includes the management of the Get Healthy service for Australia, which she will be discussing with us later. Welcome, Lyndall. I'll now hand over to Verity, who will talk you through the chronic disease services available via the Country Health SA LHN. Hello, Verity, are you there?
Thank you. So the mortality inequalities in Australia, so people living in remote and very remote areas has a mortality rate 1 to 4 times higher than those for people living in major cities, and higher rates of death due to diabetes and land transport accidents. So the mortality rate for Aboriginal Australians is nearly twice that of non-Aboriginal Australians. So again, people in low socioeconomic groups, so particularly Aboriginal and Torres Strait Islander people and those living in remote and very remote areas have a higher rate of CVD, diabetes and chronic disease. So I guess really what we're saying is for South Australia, where we're predominantly rural and remote, except for the dot of Adelaide, is that we do have much higher rates. So the same for mortality for cardiovascular disease, an increase with decreasing socioeconomic status. So it's not only rural and remoteness, it's about it's also about the socio-economic status. Sorry, this is terrible. Keep going. So mortality inequalities in Australia. So we've got higher death rates in rural and remote due to heart disease, circulatory disease and motor vehicle accidents, and also may be related to differences in access to services, risk factors, etc., etc. So this is where it gets a bit more relevant to PPAs and to country health. So as you can see, in the blue is country. So COPD is much higher in country than it is in metro, as is cellulitis. However, interestingly, we're a bit lower on UTIs and diabetes, and the diabetes in particular is particularly interesting, given there's actually a higher rate of diabetes in country South Australia. So we're not sure why that's showing up in the data. It could be that our GPs are doing a fantastic job. It could be that they're actually they're sicker and ending up in metro, which I prefer not to think is the case. The other area we're a bit higher is in asthma as well than our metro. So this is just a joining slide. So I wanted to talk about service design and what it needs to be to make sure that we've got good services. So most of you would have heard about transforming health, and basically transforming health has some principles, and as I said, even though they've been put together for this particular purpose, I think there's a lot of things in there that we need to remember when we're looking at what are good services for both metro and country. So the first one is putting quality outcomes first, and a lot of people say is everyone's worried about the cost of things and making things cheaper, and but there's a lot of evidence around that if you make things of a good quality, then safety and economic, I guess, coming in on price will just follow. So we need to try and deliver better treatment, better specialisation, better integration, better processes, and often to do that we need to transform how we deliver services. I think a lot of the services that we deliver are based on things that we've always done, and it's actually time to have a look at, well, what is it that we could do differently and what is it that we could do better. So care should be delivered in the most appropriate cost-effective venue as close to home as safely as possible. Now for country residents, I think everyone will know that country residents will always have to go to Adelaide and sometimes interstate to receive the treatment that they require, and that's just because you can't deliver everything everywhere. So, for example, as you would well know, we can't do neurosurgery in country. People have to go to metro. We also can't do paediatric, cardiac surgery in South Australia. So those children need to go to Melbourne. But it's about using the skills and the expertise we have to deliver as much as we can close to home. And also to meet the continual challenge to provide alternatives to in-hospital care for people with chronic and complex needs. This is particularly prevalent in South Australia, so what we're seeing is our length of stay dropping dramatically, and that's partly because of the improved care we can now give out in the community. So integration of chronic disease services. So some of the things that we need to think about is building on existing foundations and opportunities to cluster clinical services for people with chronic disease. And a lot of that is, a bit like when we talk about the higher end about, neurosurgery and, paediatric cardiac surgery. It's about saying those really high-end things we can cluster to make sure we can have good multi-D services, but out in the smaller remote areas we can, have either a generalist nurse or just a diabetes nurse educator, but we have a virtual team. We also need to highlight the gaps in current services and look at the best way to address those gaps. And as I said, the virtual teams are certainly one way in doing that. We need to make the best use of available resources. So certainly within country health, that we, and also out in our broader community, we need to be using our GPs and private allied health and also our country health services. So enhancing partnerships, and I can't stress this enough, is because in country we generally have much less access to a range of service providers. We need to work together as a team. So that's all of us that provide services, private, GPs, public health, etc., that we need to work together to make sure we can use, provide the best care using the resources that we've got. Recognising and facilitating clear clinical governance requirements and continuing to explore and implement innovative solutions to contemporise services. So I'll talk a little bit later about virtual clinical care. Is someone trying to say something?
No, I don't have anyone putting their hand up or anything. Can you hear us now, Verity?
I can, thank goodness for that.
Great.
We're here. Sorry, yeah, we apologise. We think there was a technical glitch with the sound that meant that some people were able to hear us and others weren't. So we do apologise, but it's very good to know that to be able to say to you, yes, we're here, Verity.
Oh, good. I couldn't even get on the system, I need to say, so I got in just as my slide came up.
Impeccable timing.
Absolutely.
All right, so my apologies, everyone. Anyway, we'll keep going. So now this slide, again, is a joiner slide, but I actually wanted to talk a little bit about it because in some respects it sums up what state health responsibility are. So you'll see up the top in the green where the complex care support, which I also like to call the pointy end. So that's where state health services often focus their attention. So it's the complex care and support, people, and we often pick people coming up, out of, as they're coming out of hospital. The idea is, to get them before they get to hospital. But I think, and you'll see down the bottom in the pink, is the primary care management, which a lot of the GPs do that, and also service management. And then in the middle with the blue is a bit of a mix. So that's where it's the team support, and the team in country South Australia will come from two parts. So one will be the private providers, of which there are not many, and the others will be from country health. So that's where we probably provide a bit more service than what our counterparts in Adelaide actually are required to do. So moving on. So chronic disease services in country. So really what I'm trying to demonstrate are what are the key things that we do, and we pretty much do across the state. And what I mean by that is this is the state government service provision or service offering. And however, having said that, we always talk about in country the postcode lottery. So some of these services you won't necessarily have in your community. So for example, in Cooper Pedy, you won't necessarily have everything that I go through today, but there is access to those. So, so the cardiac services, so outpatient, inpatient cardiac clinical services, including care planning, 24 access to a cardiologist through the ITC net, the diagnostic testing, and blood pressure monitoring and ambulatory ECG monitoring and stress testing. We have visiting specialist services in some areas, and who will often use VC, so video conferencing, and are doing so more and more. Then we've got the multi-D cardiac rehab, face-to-face and telephone support programs. So cardiac, and we've got cardiac nurses located in 11 country health locations. So respiratory services, it's really similar. So we've got the outpatient, inpatient. We've got diagnostic testing, including spirometry, lung function testing in Whyalla, and ambulatory sleep studies in Whyalla, Port Pirie and Port Augusta. So you can see that they're not available across all of South Australia, but certainly in some key spots. Domiciliary home oxygen we do provide, again, a mix of visiting specialists and multi-D pulmonary rehab face-to-face services. And certainly looking at how we can do that differently using video conferencing and app-based services. So, and respiratory nurses located in 11 country health locations. So diabetes, I guess this is where we probably have the most, the greatest coverage. So again, we have outpatient, inpatient diabetes clinical services, including nursing and allied health, so podiatry, dietetics, social work, orthotics, and prosthetics. We offer insulin titration support services, visiting specialist services, and we've got a couple of nurse practitioners, one in Adelaide, one in Mount Gambier, and one in Wallaroo. When I say the Adelaide one, they actually provide support to our diabetes nurse educators across all of country South Australia, and multidisciplinary diabetes support programs, which are often delivered face-to-face. We've got diabetes nurse educators located in 26 country locations, and a number of those provide outreach clinics to a further 19 sites. So, and we've got diabetes link nurses located in 14 of our hospitals, a small hospital. So I want to talk a bit about virtual clinical care. So virtual clinical care enables us to expand services in a resource-poor environment across 1 million square kilometres. So I was talking before about what services we've got, and a lot of those are the face-to-face ones. And so this is an opportunity for us to use technology to, I guess, improve access. So the strategic goal was to create an integrated patient-centric technology-enabled chronic disease model that re-engineers existing services to incorporate intensive periods up to 3 months of remote monitoring, and I'll come back to that. Also improves patient outcomes and empowers patients to be more involved in managing their disease. Reduces PPAs and emergency presentations and facilitates equitable access to healthcare. So that was the strategic view when we looked at getting into this. So the benefits, so again, expands availability. What we've seen is reduced transfers and trips to Adelaide, early detection and management, and preventing hospital admissions and shortening stay in hospital, because we can use it as a way for GPs to be assured that people are getting monitoring that without having to sit in a hospital bed, and more appropriate and planned utilisation of health services, and improvements in safety and quality. So, and I'll talk a bit more about how it actually works, but since April 2015, so it's still relatively new, we've had 200 clients, it's probably a bit more than that now, that's been supported, and we've been focusing on COPD, cardiac failure, diabetes, hypertension, or a combination of these conditions through remote monitoring. And what we've found is many of the people that we've supported have had a combination, so the comorbidity stuff, the pointy end stuff, and that clients are set up at home with devices to take daily measurements with results linked to a database accessible to all members of the healthcare team, including GPs. So they're things like blood pressure monitors, also your blood glucose, there's O2, etc. Now, I was asked recently how does it all work. So how it works is the patient is set up by one of our teams, so we give them the monitoring equipment that they have. We also give them a tablet. It's not an iPad, it's a what do you call it? Anyway, it's like an iPad, but it's a tablet on which we've loaded an app, and each of the devices is Bluetooth enabled, which talks to the app. The app then uses the 3G network to transmit the data to ICCnet in Adelaide, where they monitor it. And when our clinicians set up each of the patients they basically work out what their normal parameters are. And so if the client if the reading comes back that's outside of those normal parameters, then contact will be made with the patient. And so that contact might be from the clinicians that are monitoring the data in Adelaide. It might be from a local community health nurse. It might be, if we've been working with the GP, it might be from the GP, or if it's really quite serious, then we would be recommending an ambulance attend. So, so that's how it works. And next slide. So, is that going forward or back? This must be a duplicate slide. So the other thing that we found is it's better to use VCC short term, and so we generally offer 6 weeks, and the reason for this is not only so we can keep people offer the service to as many people as we can, but it's also that we found we're getting pretty good outcomes after 6 weeks. So we're finding that after 6 weeks, people are having a better understanding of their symptoms and their readings, and have learnt some more skills in self-management. So there's a couple of really good stories that have come out of this, and one has been about people with COPD in particular, who one of the main reasons for presenting to hospital was actually anxiety. So their breathing become a bit laboured, panic, and it would get worse. And so therefore they would present to hospital. And what the feedback we've had from people with COPD on this program is even when they've been short of breath, they've been looking at their results themselves thinking, oh, it's actually not that far out of normal, no need to panic, I could manage this. So that's been one of the really good outcomes. The other really positive outcomes have been a couple of people have lost weight, because that's the other one that gets measured is weight. And a few of the clients have said, I have lost weight because I've been too guilty that when you ring me, because we ring them anyway, at least once a week, is that if he hadn't lost weight, he was feeling guilty. So there's been a number of those. We've certainly seen reduction in emergency presentations in hospital, and overall it's been really positive outcomes. So next slide. So just one quote is about, I would never have known I had BP issues without the trial. I often feel really crappy and didn't know why. I now know it's because of my high BP and starting to get on top of it with my GP. So I think VCC is wonderful. So one of the other questions I've been asked previously is about what about older people who aren't very tech savvy? And again, we've had the failure rate has been almost nil. Is that the old people can really take to this because it's easy to use. So when we give them the tablet, it's not full of 3 million different apps. It's just got the one app on it. So that's been designed so it's relatively easy to use, and they can work it out pretty quickly. So we actually haven't had any issues with the fact that it's technology based, even for our older clients. So early detection and intervention, improving quality of care, effective use of the health service, as I said, at value adds, and real-time clinical information to improve management of vulnerable information. So that's the other benefits, that it is real-time. It's continuously updating, so every time they measure their blood pressure, it will come through. So, sorry, I forgot we're on to flexible funds. So one of the things that we're talking to the Commonwealth about is looking at whether there's a way that GPs can utilise VCC with their support. So keep an eye out for that. So as I've mentioned previously, where country health or the state health sits in terms of what we deliver, it is up the pointy end in terms of people with chronic disease. However, through the Commonwealth, but through the PHN, have a funding stream called flexible funds. So historically, flexible funds was a whole gamut of things. It was called the regional primary health care initiative at one point. It was called a whole range of things. It's been around for at least 15 years. But originally it was very much around what does the community want, and so what we were seeing is very little, a whole plethora of different things being offered in different communities, with many of them being focused on community development. So what the Commonwealth has said now is that they would like flexible funds to be used predominantly to increase access to allied health and specialist nursing, and preferably in the area of chronic disease. So the PHN funds Country Health to provide flexible fund services, and the goal of that service is, as I said, GP-led but multidisciplinary in nature, where the flexible funds can provide diabetes nurse educators and other specialist nurses, allied health, and then they can be supported by care coordinators and allied health assistants where required. So obviously a number of practices have practice nurses that act as care coordinators, so we need to use the flexible funds funded care coordinators, and also it enables us to provide chronic condition self-management programs. So it's a good opportunity to really expand the services that we can. The other bit of history behind flexible funds is that it's about improving access, particularly for allied health and specialist nursing. I mentioned before that Country South Australia has only 1/3 of the number of allied health providers that what Metro has. And part of that is about economies of scale for private providers, is you need to access every MBS item you can, and you need enough people doing that to make your business viable. So if anyone online is from any of these locations, then flexible funds is available. Now the locations has been from Country South Australia PHN wanting to focus on communities of less than 5,000, pretty much for the reason that I just discussed, being that you know, of communities of greater than 5,000, there's a greater chance that there could be private providers available, but certainly in communities of less than 5,000, there's not. So in the far north, we've been servicing Coober Pedy, Udina Data for quite a long time under these funds, but we're just in the process of establishing more service in Marla, Mintabee, Maree, Roxby Downs and Andamuka. Hawker Lee Creek, established for a while, all of Eyre Peninsula excluding Port Lincoln, over 5,000 people, as is Whyalla obviously. Mid-North, Peterborough, Jamestown, Orroroo and surrounds. Central and Southern York Peninsula, so Maitland, Minlaton around that. And further south to Ardrossan and Arthurton, Yorktown. And then lower north, so Clare and surrounds, and Mallee, Karoonda, Pinaroo, Lameroo and surrounds. So that's where flexible funds is available. And again, if any of you are working in those areas, then I'd really encourage you to link with your local community health services through Country Health and inquire what we can do to support you to manage your clients with chronic disease. Similarly, I mentioned about the pointy end. You're also, please contact your local community health service if you have people with quite complex needs, and we can certainly support with dietetics and podiatry and diabetes nurse educators. I wanted to just finish with a bit of bad news and a bit of a plug around diabetes foot screening. So, next slide, thanks. So basically, South Australia has the worst amputation rate in Australia, and Country South Australia is worse than Metro, and it's predominantly related to diabetes foot disease. So our rate is currently at 21 amputations per 100,000 population, which is not good. So what Country Health would love to do with a range of GP providers and the PHN is to work together to increase the rate of diabetes foot screening. And of course, foot screening can be done by GPs, it can be done by practice nurses, it can be done by other people trained, so it might be in aged care facilities or wherever else that people want to do it. So in Scotland, they developed and implemented a model which saw a significant decrease in the number of amputations, and we just happen to have advanced clinical lead podiatrist whose name is Fiona Murray, who we recruited from England, and she knows the program inside out, and will be presenting to this via webinar around this very topic in December. I think the date's yet to be confirmed. But what it looks at is the well-coordinated screening by multiple discipline and staff groups, and that there's online standardised screening tools accessible, risk stratification of all clients with diabetes to determine levels of intervention. So in other words, work out the risk and then send them to the right place to get the right treatment. Skilled multi-D foot teams with fast access pathways. Once we get this information, we can better target podiatry resources. We'll be looking at ward awareness programs as well, and also offloading insoles available by health services and subsidised. So Fiona will also talk a bit about the program that we have running using foot scanners that can be for orthoses and also specialised footwear for people with high-risk feet. So I'd encourage you, if you have an interest in the diabetic foot screening program, to get along to that session when it's made available. Is there any questions?
Thank you so much, Verity. That was great. I'm just going to ask Sarah to see if there are any questions in the chat pane.
No, I don't think so. If anybody has any questions, they're welcome to put their hand up and we can unmute you. And I'm trusting that everyone can hear now. Perhaps pop your hand up if you can hear. Great, thank you.
Thank you, Verity, so much for giving us all of that information. And for all of the participants who've joined us today, once the date has been confirmed for the foot screening, the Diabetes Foot Screening Program webinar, we will email you directly and let you know when that webinar will be on. So thank you so much to Verity for taking time out of her very, very busy schedule to join us today, and for giving us such a comprehensive overview of the service provision available in Country Health SA.
No worries. Thank you all. See ya.
Thanks, Verity. I'm now going to hand over to Lyndall Thomas, who I introduced earlier, and Lyndall will be talking about the Get Healthy Information and Coaching Service. Hello, Lyndall.
Hello, thanks Katie. Hello everybody. Yes, I'm going to talk to you today about the Get Healthy service. This is the key service that SA Health is making available across South Australia. It's free, and we've been providing this service now since the beginning of 2014. Get Healthy was originally developed by New South Wales Health and has been running there since 2009. So Get Healthy, it's a free telephone lifestyle coaching service. It was really developed as a chronic disease prevention program, but it's perfectly suitable for people who have existing chronic diseases such as type 2 diabetes or heart disease, who need to make changes to their lifestyle to help manage those chronic diseases. The focus is on healthy eating, physical activity and healthy weight. So it's not a service to help people quit smoking, and alcohol is really only dealt with in terms of its contribution to a healthy diet. The coaches are all professional people, so they're all nurses or qualified allied health workers, and every participant is, has his or her own personal coach through their time using the service. Participants, the program offers up to 10 calls over a 6-month period, and those calls are more frequent at the start of the program and then less often as they become more of a follow-up and relapse prevention type of support. So the sessions cover helping people to identify what they see as their main problem, setting SMART goals, so those, I'm sure you're familiar with what that term means around SMART goals, exploring options with them for how they can achieve change, what sorts of services are available, what sorts of activities they can undertake themselves, helping them to understand the dietary guidelines, that sort of thing, and how to maintain their motivation so that they can be successful in making change. So there's no specific eligibility criteria for Get Healthy, and people can self-refer. They can do this either on the phone or through the website. The initial call to the service includes quite a extensive initial assessment screening questionnaire, and from that some people will be required to get a GP clearance, and this is particularly for those people who have complex comorbid problems or perhaps poorly managed health problems. But it is possible for GPs or other health workers to make referrals, and you can find a referral form on the website. If you do refer people, well then you should receive feedback about that person, particularly whether they have actually enrolled in the service, what their goals are, and then progress updates at the midpoint and on completion of the service as well. If you make a referral and the person chooses not to engage with the service, you should be advised of that, or if they drop out along the way. So it's a good way for you to get some sense of whether people have taken up your advice that this might be a good service for them to use, and for you to know how they're progressing with the service. So all the participants that use the Get Healthy program receive these booklets. The information booklet, it's just that. It provides information about the Australian dietary guidelines, and so what is part of a healthy diet, understanding labels, serve size, that kind of thing. And then they also receive that journey booklet, and this booklet provides some additional tips on how to set goals and maintain change. It includes pages for them to record goals and diaries to record change that they're making, and this is helpful too when they're talking with their coach on their regular calls, so that they can look back and say, oh yeah, well actually last week I know I said I would eat an extra serve of fruit every day, but well, I actually only did that on 2 days. And that gives the coaches an opportunity to talk about, well, what kind of things went wrong for you during the week. Maybe that goal was too hard, or you know, maybe those things were just one-off things, and so you can get back on track for the following week. So most people understand that writing down commitments and recording your actions are a good way to keep on track. There's a really good website that goes with Get Healthy. It provides quite a lot of information for participants, but there's also a tab for health professionals, and in that tab is where you'll find the referral form, and also quite a lot of promotional material. So we've got some leaflets and posters and brochures and that kind of thing. There's an order form there, so if you want to order any resources yourself, you can just print off the form and order the things and send that away, and they're all provided free of charge. We have also had a number of resources translated into other languages, and so while we're not making them available in a printed form, they're there for you to download if that's of any assistance to you. So a collection of posters and brochures that have been translated into about a dozen or so different languages. So back in the middle of the year, we contracted an agency to have a look at our data from when we commenced the service through to June this year, and we were quite happy with the results. Significant weight loss of 3 kilos, weight circumference loss of just over 3 centimetres, and a decrease in BMI, and also almost a whole serve of vegetable consumption. And I know that doesn't seem like a real lot, but Katie's slides included that about only 11% of people are eating 5 serves of vegetables a day. We know 5 is a lot, and we know there's a seasonal change for that. People eat more vegetables in the winter than they do in the summer. Fruit, we didn't get much of a change in fruit, but more people get their 2 serves of fruit a day. But we were also happy that we were getting the service to the right people. About 90% of people were either overweight or obese. So, you know, we're not really getting the worried well who want to lose a couple of kilos. 66% of the participants were aged between 30 and 60 years, so that's good. We don't exclude people who are older because it's important for people, you know, to be as healthy as they can for as long as they can, but we really are trying to target people at that age before things go too far wrong for them. 30% of people live in regional or remote areas, so that's good. That's about equivalent to the population split, and about 3% identified as being Aboriginal or Torres Strait Islander, probably Aboriginal, and that again reflects the population rate in South Australia. So we're pretty happy that we are targeting the sorts of people that we're aiming this service for. And about 8% reported that they've got type 2 diabetes. So that's fine too. As I said, it's an ideal service to help those people learn how to improve their diet, be more active, which is really key to managing their diabetes or other chronic disease. We've had about 16% of people graduate, a little bit lower than what we would have hoped for. We would have been hoping for around about 20% for this type of program, but about 35% of people have had more than 5 calls, and there's quite a lot of evidence to show that not everybody needs to work the whole way through a program. Sometimes just talking to somebody about how you go through the process is enough. So if we're getting, you know, 40 or 50% of people having 3 or 4 calls, for a lot of those people that will be enough for them to be able to progress on their own and make good changes to their behaviours that will provide long-term benefits for them. There's also nothing to stop them from coming back into the program and having another try at another time if they choose to. Another disappointment, of course, but also common with any kind of behaviour change program, only about 18% of our participants are males. So if you can encourage the men out there to give this sort of a program a go, well, that would be a good thing too. And so just finally, I just wanted to alert you to a couple of new modules that we'll be accessing next year. New South Wales, who take the lead on developing this program, given that it's theirs, have developed a couple of new modules that we'll be accessing. Firstly, the Get Healthy in Pregnancy. So the focus is on a healthy weight gain in pregnancy. So it's available to women. They can start at any time through their pregnancy. So even if they start later on, then they can continue to receive calls after they've delivered their baby. Or of course, if they've had all of their 10 calls while they're pregnant, and then at some time later, they can come back and join the program again after they've had their baby. It's essentially the same program with a focus on healthy eating, being active, and all the coaches have had additional training on what's appropriate and sensible for pregnant women and breastfeeding women, for those after they've given birth. They receive those same print resources as well as a few additional resources that have specific information relevant for pregnant women. The other module that we'll be accessing is the Diabetes Prevention program. With that program, all participants that are 40 years or older and all Aboriginal participants will complete the AUSD risk screening tool, and I'm sure you're familiar with that. So for those people, if they score 12 or more, then they will receive an additional 3 coaching calls, and those calls really are at the start of the service and will focus quite specifically on their individual risk factors for developing type 2 diabetes. Now, I guess there's not much that they can do about age, and you can get a lot of points, you know, for being older. But to have scored 12 or more, you must have some other risk factors as well. So, you know, maybe it's about, you know, having a poor diet or not being active enough, a family history. So, again, you can't really change your family history, but you can be more proactive in making sure that you're doing everything you can, linking in with GPs. People, of course, who score very high will be encouraged to go back to their GP to have more thorough investigations, because perhaps they already have diabetes. So that's really it from me. Just a quick update on Get Healthy, hoping that if you're not already familiar with it, you'll go to the website and check out the details there and start thinking about who in your service might be able to make use of it, recognising that it is a free service. We've got plenty of capacity to take more referrals, and that's a good service that you can use together with perhaps people that you're working up care plans for, or just to promote more generally in your practice for people to just see that, oh, well, here's something that might be useful for me, and they can self-refer if they choose. So thank you for your time.
Thank you, Lyndall. Yeah, it's a great program, and we've had feedback actually from a practice nurse at the first workshop we ran on chronic disease prevention, who suggested it's good, really good for a couple of specific cohorts of patients. One are those that may have transport issues or accessibility issues to allied health programs, so that whilst they may not be able to attend a face-to-face program, this represents involvement in a program over a phone with that one-on-one coaching. And the other group are those who may have some mental health issues, particularly with anxiety. And again, they may not feel comfortable participating in a face-to-face exercise class or a group. And talking to someone over the phone rather than that personal contact is really quite helpful for that group of people too. So please do use the service. We really, I used to work in New South Wales, and it's very, very, very well accepted and utilised over there. So let's make South Australia do the same thing.
Thanks, Katie.
So I'd like to finish by just letting you know about the upcoming webinars that we have for over the next 4 weeks. So every Tuesday lunchtime from 1 to 2 p.m. for the next month, we will be holding the other webinars in this series, starting with Foundations for Change, which will be next Tuesday. And the lovely Sarah Raverstein, who's joined us today, will be running that session. And that's really going to look at how to build and maintain your team and support your team in the work of prevention, and also the use of recall and reminder systems. Following that, Dr. Ralph Audham from Victoria will be talking about, we'll be using a case study to demonstrate the use of risk assessment and screening tools. Ralph is a Melbourne GP and Associate Professor at the University of Melbourne, and he has a passion for managing people with chronic disease as well, particularly those with diabetes and heart disease. He's implemented many programs for diabetes management and prevention, refugee health, children in out-of-home care, and he is the chair of the expert reference group for the diabetes topic here at IF. And so the week after that, we have Prashiba Thavarajadeva, who is a practice manager at Mawson Lakes Healthcare, Montague Farm Medical Centre and Ingle Farm Family Practice. He previously worked in the corporate sector in telecommunications and finance, and is a qualified engineer. So he's got a very interesting background. Prashiba has many, many innovative ideas regarding engagement of patients, particularly with the use of modern technology. The way that his practice uses social media is really very clever. And to finish the series, we have Ros Rolliston, who will talk on nurse-led clinics. Ros is a primary healthcare nurse and educator from Nowra in New South Wales. She has a wealth of experience in both the acute and primary care sectors, and is doing her last unit in her Masters of Nursing, which she's very happy about. And earlier this year, Ros began a new role as the Skip into Life Project Manager at Warragee Medical Centre. Skip into Life is a nurse-led clinic for people with mental illness. And in the final webinar, she will take you through the journey of her nurse clinic. And as I say, we'll also show you how to maximise your practice revenue with the best use of MBS item numbers for prevention. So if you would like to register for all or any of these other sessions, please do so via our website, www.improve.org.au. And we hope that you'll be able to join us and hear some of these very interesting, experienced and passionate speakers. So I'd like to say thank you to Verity and to Linda and Sarah who've joined me today. I hope you've enjoyed today's session as much as I have, and I hope that you'll be able to join us in the future. Thanks and have a great afternoon.